this whole role of cannabinoids in the treatment of epilepsy. And this is also very similar to the history of dietary therapy. And I think if you look at dietary therapy in this, it's fairly humbling that these are not new concepts. These are concepts that have been talked about for thousands of years. And so just looking really quickly at the history of this, cannabis has really been used for thousands of years. It was the first non-food crop yielding crop in China, and it was cultivated for garments, bowstrings, paper, and medicine. And one of the first references is in 2700 BCE, so a few years ago, where it was recommended for menstruation, gout, rheumatisms, malaria, constipation, other ailments. And then 1200 BCE, the Egyptians used it for glaucoma, inflammation, and enemas. And medical use is also documented in ancient India, Africa, Greece, Rome, and the Arab world. So pretty widespread utilization of cannabis in the treatment of different ailments. In epilepsy is actually first mentioned in Sumerian texts. These are stone tablets from 2200 BCE that cannabis was used to treat nocturnal epilepsy. And then kind of from the middle, this is Middle East now, these countries, 1100 nasal treatment of cannabis leaf for seizures, and then kind of more the regular use of cannabis for seizures. If you come more current times, in 1842, O'Shaughnessy reported cannabis reduced infantile convulsions and other disorders, and in 1878 was also the report of cannabis leading to seizure freedom in a 10-year-old boy who had focal epilepsy. In 1881, William Gowers, and this should be of great significance to the neurologic community because Gowers is one of our most famous historical figures in neurology, reported that cannabis had been recommended for epilepsy by Russell Reynolds in 1961 as sometimes, though not frequently, useful. And then he actually administered cannabis and wrote about this in many cases with the effect of delaying paroxysms and mitigating the severity in some individuals. In 1851, in the U.S. dispensary, cannabis compounds were suggested for several disorders, including neuralgia, depression, hemorrhage, pain relief, muscle spasm, convulsive disorders, and other ailments. And in 1860, the Ohio Medical Society on cannabis, the efficacy was claimed for infantile convulsions, epilepsy, and many other disorders. And then things changed, and I think we can thank my country for this. In 1911, in the setting of prohibition, Massachusetts, which Lisa and I was shocked by this. We consider our state kind of liberal. We're blue. Massachusetts was the first state to outlaw cannabis in the setting of prohibition, and the other states quickly followed marijuana prohibition laws. And in 1970, the United States Controlled Substances Act passed, classifying marijuana as a drug with no accepted medical use. So isn't that shocking? After thousands of years of evidence that this might be a treatment, suddenly in the setting and because of prohibition, it's decided not. But things have been changing in 1996, and I think this started all of this now concept of medical marijuana. In 1996, California became the first state in the United States to legalize medical marijuana, and earlier this year, it was legalized in 23 states, regulated at the state level, which makes it complicated and interesting, but difficult. And there kind of had been increasing anecdotal reports about the efficacy of medical marijuana, especially CBD-enriched formulations, in the treatment of refractory epilepsy. Now, I've never smoked marijuana, but I'm extremely interested in it. It's a complicated plant, over 500 chemicals. THC, it's the only plant that contains these cannabinoids. And what's interesting to me about it is our brains have receptors for cannabinoids. So why this plant has these chemicals that our brains have receptors for has been intriguing to me. THC is a cannabinoid. That's the one that has psychoactive properties. Cannabidiol has no psychoactive properties, and that's the one that's thought to be potentially effective in epilepsy. So about 2.5 years ago now, with this increasing anecdotal thing over the web, social media, people using this, a group of five academic centers, including us, got together with a company in the UK, GW Pharma, which many of you have heard of, that have products. They had a cannabidiol. And we decided to ask the United States government, the FDA and DEA, for permission to put kids on this to see if it was effective. In order to do this, I was allowed initially 25. I now have 56 kids under this IND. We had to write little stories about each kid to the DEA and FDA, showing that these kids were with the most highly refractory epilepsy we had. They'd been on 10 medications. Most had either surgery, had been on diet, had the stimulator, and still having seizures per day, showing these kids really don't have options. They need to have the opportunity to try this. Of that, because I had this big interest in TSC and epilepsy, I had initially had 5. Now I have 16 patients with TSC on cannabidiol. under this expanded access IND, all of them, again, with the most highly refractory epilepsy of my epilepsy patients. And we have done interim analysis on 10, and this is going to be presented at the epilepsy meetings in a couple weeks. Average age is 11, kind of more boys than girls, many with the TSC2 mutation. And what is looked at in epilepsy trials now is called the responder rate. And that is what percentage of people have a 50% or greater reduction in seizures. That's a responder. And kind of then also obviously interested in side effects, because this is really safety, tolerability as well as efficacy. Found that there can be diarrhea, and that's because it's in an oil. So the more volume of oil, sometimes diarrhea. And then very important also to know is there can be significant drug interactions, particularly with clobazam, as well as valproate. And important in the United States to know, because many people are putting their kids on very different variations of medical marijuana, and a lot of these kids are on these drugs. And if they're not followed, levels aren't followed, then this isn't appreciated. The kids can have pretty significant difficulty with profound lethargy, change in liver functions, et cetera. But anyway, what we see is it can be really helpful in TS. And this is over the response rate of these different months. But I think if you look here at the 12 months, the fact that these kids, there's a greater 50 to 60% response rate. And again, remember, these are my most refractory epilepsy patients. So anything that can reduce their seizures by 50% to me is pretty wicked exciting. And one of the kids is seizure-free after 2 months. And this is a kid I've known on and off for years. She had epilepsy surgery with us years ago, moved away, came back about a year and a half ago, and her brothers came with her. And her brother said, "You have to help Marissa. We've lost her." And at that point, Marissa was completely, basically non-interactive. She was having continuous atypical absence seizures. So we put her on the Epidiolex under expanded access, and she's been completely seizure-free for 9 months. Now it's going on a year. And actually, she comes back now, you cannot shut the kid up. And so her mom is like, now she's really driving me crazy. Because she's like chatty Cathy. I like this, I like that, but anyway, so it's been pretty incredible for her. And in addition to seizure control, we've had parent-reported improvements in alertness, verbal capacity, communication, vocalizations, cognitive ability, initiation of emotional and physical connections. Now, this you have to take very cautiously, because one of the concerns about this is there's such hype in the United States for possible medical marijuana that we know could be a huge placebo effect. If I put my kid on this, I have such great hope that this is going to work, that I can see my child no longer be autistic, no longer be anything. And so that's why the randomized controlled trials are so important. But based on our stuff on the IND on these TS kids, GW Pharma has announced they've filed with the United States, and these will be international studies, that there will be TSC-specific studies with cannabidiol. And they will be starting soon. And there is great interest they have, and they have talked with John about possibly there being a site in Australia. So I think you guys could be hopeful that hopefully there will be a site here for this study. The inclusion criteria will be a pretty broad age range, and I was really excited about that. That will include not only children, but also adults. Well-documented seizure history, diagnosed with TSC, stable on all medications, because when you go into trial, you want to see what your study drug is able to do. No changes during the trial. No medical marijuana or cannabis-based trials during the trial, so that makes sense. And then baseline to include greater than 8 seizures during a baseline period. The exclusion criteria, or the folks have had pseudo-seizures, because it's going to be hard to track what's a real seizure and what's not. Illness or anesthesia in 4 weeks prior. Surgery for epilepsy 6 months prior, if they're on Felbitol. If they're on an mTOR inhibitor, and part of the reason for that is the mTOR inhibitors are currently in clinical trials for epilepsy. You cannot be on 2 investigational drugs at once. So even if a person is on an mTOR inhibitor for renal AML, that would exclude them from this trial. The topical rapamycin honestly should not, because that does not get absorbed. Hepatic dysfunction, suicidal thoughts, and that's true for any seizure trial right now, and then any use of recreational marijuana. And kind of what's going to happen with this is there will be a 4-week baseline, so folks will enroll, then a baseline so you can track seizures over that time. 4-week initiation of drug, 12-week observation, and it will be a 1/3 placebo, 1/3 one dose of CBD, another third a higher dose of CBD. No one knows, we don't know, people don't know what they're on, and then at the end of that observation phase, anyone can go into open label phase, and then everyone will get drug. So again, these are the things that will be measured, but I think that they're in the United States, and I know kind of increasingly around the world, there's a lot of interest and excitement, and this is not the silver bullet for epilepsy and TS. It's not the silver bullet for epilepsy in anything, but I think it's a very safe and well-tolerated medication, and I know it can be helpful to some people. And so with that, I'd like to stop, and thank you guys very much.
Yes, welcome. It's great to be having this meeting again. This is the third similar meeting I think that we've held with this combines scientific stream or medical stream and patient stream, patient and family stream. Back in 2000, in this part of the world that is, back in 2007, David Franz came and was at that stage telling us all about the exciting stuff that was happening in Cincinnati with mTOR inhibitors, and Chris Kingswood was talking about kidneys and his experience with kidneys. In 2011, we had Petrus de Vries talking about the neurological, cognitive, psychological things that we all call TAND now, and Vicky Whitmore from the NIH giving a bigger picture view of research and cooperation between families and science, and David Franz came back. And then this year we're moving on and looking differently, and we've got Lisa and Elizabeth with LAM and neurological and epilepsy. And again, the really exciting thing is both are world leaders, are truly world leaders, international experts, like our previous speakers, and so it's a great privilege to have them here today. The program, as you can see, we're sort of trying to expand out a bit. We're looking at TS as an intergenerational condition, and particularly in the next session in the medical stream, looking at really from preconception through the whole life cycle and all the issues that are involved, and not just the traditional things about managing your SIGAs and your AMLs, but much more a holistic view of the patient, I think. I think there are a few medical students here. I think a few are registered, and it's great for them. I think this is a great opportunity for them because TSC, in a way, is an exemplar of a 21st century medicine and how it works. And if I don't think medical students use textbooks anymore, but if any of them were to pick up a textbook, from the 20th century, the textbooks of TSC was that textbook picture of that child with tuberous sclerosis. And now we know that TSC is so much more, so much a spectrum of manifestations across all different ages. And we know that through sort of great research and cooperation between basic scientists that are here today, through to clinicians, collaboration between multidisciplinary teams, collaboration between paediatrics and adult medicine, and we've got representatives of them here, across state boundaries in Australia, and even we have, as Deb said, friends from the great cricketing nation of New Zealand. You're going to give Richie McCaw a bowl? But particularly for students, I think it's a fantastic insight to see how that cooperation between the medical side, the researchers and the families and the patients leads to great initiatives and advancements. Because it's from us listening to patients, we find out what are the important things that we should be looking at, should be researching, we should be trying to understand. So welcome to everyone, and really looking forward to today's program, but I hope everyone has a great couple of days. So thanks, Debbie.